All right, to all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedules, so check back often. This video will be available for review after the Journal Club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to substitute professional medical advice, diagnosis, or treatment. So always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition, and never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. We are looking for an athletic trainer to join our team. This is a full-time clinic-based position working in a sports medicine clinic. Please feel free to pass our information along if you know of a qualified candidate, and more information can be found on our website. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the questions and we will review them at the conclusion of the presentation. And if you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from the website tomorrow. Dr. Miho Tanaka is a sports medicine surgeon recognized for her research in patellofemoral disorders and gender-based differences in orthopedic injuries. She joined the Massachusetts General Hospital Sports Medicine Center in July of 2019. Prior to her arrival, she was an associate professor of orthopedic surgery and the founding director of the Women's Sports Medicine program at the Johns Hopkins Hospital. Dr. Tanaka completed her undergraduate degree at Stanford University, where she was a member of the varsity track and field team. She earned her medical degree at New York Medical College, and she completed her orthopedic surgery residency at the Johns Hopkins Hospital in Baltimore. After residency, she completed a fellowship in sports medicine and shoulder surgery at the Hospital for Special Surgery in New York City. She has served as a team physician for multiple professional, semi-professional, and collegiate sports medicine teams, including the St. Louis Cardinals, St. Louis Surge, Johns Hopkins University, and the U.S. Soccer Federation. She has published and presented over 80 articles and book chapters with a primary interest in the anatomy and biomechanics of the knee. She also serves as the chair of multimedia for the American Academy of Orthopedic Surgeons and is a member of the Education Committee for the Arthroscopy Association of North America. She additionally serves on the Electronic Media Editorial Board for the American Journal of Sports Medicine, on the editorial board for the Arthroscopy Journal, and on the Associate CME Editor Panel for the Journal of Bone and Joint Surgery. She is presenting today on the evaluation on women's sports medicine. What is it and why should we care? And I'll have her take it away from here.
Thank you so much for that nice introduction. Can you just confirm that you can see my slides again, because I switched things around? Okay, fantastic. Well, thanks for the opportunity to give this talk today. So I'm going to be talking about women's sports medicine. These are my disclosures. So anytime I give this talk, I always like to start with this video. Hopefully there's some sound here, so I hope you can hear it.
23 years old, first woman in the majors.
Never miss a moment.
So I love that video because, even though it's an AT&T commercial from a few years ago, it really encapsulates, I think, what women's sports medicine is all about. And so that's what we're going to be talking about today. We'll start with the context and the history of women's sports and how this has influenced the field of women's sports medicine. We'll talk about the issues that are specific to female athletes. And we'll also talk about how this is relevant to us as orthopedic surgeons, physicians, athletic trainers, physical therapists, and what can we do to make a difference. A little bit about my background. I started out, I guess you could say, as a female athlete a million years ago. I was on the track team at Stanford, and it was really when I got into practice, though, that I started recognizing the need for care that was specific to female athletes. And in my first job, I was actually part of the team that was taking care of the St. Louis Cardinals. And it was an incredible opportunity where I got to work with really elite level athletes. But it was during this time that I started to see a lot of second opinions for problems like missed ACL tears and, missed shoulder dislocations in female athletes, and I couldn't really understand why this was happening. And so this is where I started realizing there was a real need for this type of care, and I organized the Women's Sports Medicine Initiative, which then grew to be a 300-member group with national membership that basically worked on raising awareness about the issues that are specific to female athletes. From there, I got recruited to Hopkins and subsequently now at MGH and Harvard to build their women's sports medicine programs. And the crux of this program is really about three things. One is to provide comprehensive care for the female athlete. Second is to raise awareness about the injuries and issues that are specific to female athletes. And lastly, to advance the knowledge regarding the diagnosis, treatment, and outcomes for injuries in women. So our women's sports medicine program is not just about orthopedics and sports medicine, but we have primary care, internal medicine, endocrinology, obstetrics, as well as physical therapy, MSK radiology, psychiatry, concussion management, and even sports cardiology. So it's a lot of people. Well, why do we need this program? Well, we all know that males and females are different. We know that the anatomy is different. We know that the personalities are different, which means our social interactions and even the way we interact with our teammates and coaches is different. The incidence of injury is different. And then the opportunities are different as well. So there's no Major League Baseball currently for women. There's no NFL for women. And so that means that the opportunities for care vary as well. When we talk about the gender gap, we know that more than 50% of current collegiate athletes are women, but less than a third of that money is spent on female athletic spending and recruiting, and less than half of that is spent on women's athletic scholarship dollars. If you look at the women's NBA, this is kind of the classic example, maybe some old numbers, but still not far from this. The average salary is about $70,000 with the cap of a little over $100,000, I think, or at least the high, the last I heard, versus in the NBA where the average salary is over $5 million. So this is a big difference. And this has more recently come to light, right? Since the 2019 World Cup, where the men's prize, I think for the entry level prize was the same amount as the first prize award for women. And so there was a complaint that was filed and people are starting to pay more attention to this. Well, some people would say, well, why should we care? Why women's sports is maybe not interesting. Women can't dunk. There's a lot of arguments to be made that, I've heard a ton of. But I think if you look at the history of women in sports, the first time that the Olympics were held was 776 BC. And the first time that women were allowed in the Olympics was in the 1900s. And in 1900, these events were actually limited to specific feminine sports that protected fertility, respected decency, and avoided strenuous or sustained effort. I'm not really sure what kinds of sports fall into those categories. Swimming and diving was allowed in 1912, track and field in 1928, and there's all these great stories if you look back into the history. But you know, I think for many of us, we think about the Olympics and how we think of it as pretty equal, but the 64 Olympics was only 13% women. The 83 Olympics was only 23% women. And in 1996 was when women's triple jump, which was my event at Stanford, actually became an Olympic event, right? Women's NBA also established in the 90s. And so all of this in the history of women's sports is a lot more recent than people recognize. And the majority of these changes happened around and because of Title IX. As we know, Title IX was the Educational Amendment Act that prohibited sex discrimination in education, and it required that schools provide female students with equal opportunities to play sports, have their fair share of athletic scholarship dollars, and provide equal benefits and services to male and female athletes overall. And it was after Title IX that we started seeing increasing number of female athletes that pretty much has doubled each decade. We've gone, even though for boys, high school sports, this has grown from 3 million to 4 million. For girls, we've seen a change from about 250,000 to over 3 million currently. And we're seeing the same trends in terms of our collegiate sports over the past 40 years. But it's not just the number of female athletes that we're seeing is changing, it's the type of sports that they're playing as well. And our study showed that the most rapid growth in girls sports over the past 20 years was actually in ice hockey, wrestling, and even football. And so I think this brings up the question of what defines a women's sport. When we look at the percentage of the high school players that play each sport and what percent of those are women, this has been changing over time. And again, this study showed that wrestling and ice hockey were the fastest growing in terms of the percentage of women that were playing in these sports. And so I think that this is an important consideration because, you know, as this field changes, our understanding of injuries changes as well. In the 70s, you know, one of my mentors once told me that when he trained in the 70s, there were actually no women who had ACL tears because it was before Title IX. Women didn't really play a lot of sports. If they did and they tore their ACL, then there weren't really opportunities for them to play in college or play professionally until later on. And so there wasn't a lot of treatment and care for ACLs in female athletes, which is hard to imagine given how many we see currently. It was in the 80s that we started seeing the increasing number of female athletes, and in the 90s where we started recognizing, wow, really high rates of ACL injuries in this population. In the 2000s, we started thinking about ACL injury preventative programs, which we're still talking about today. And now I would say for this decade, maybe gender-specific protocols, maybe thinking about how there's new sports and new mechanisms of injury, but the field is continuing to evolve. We'll talk a little bit about ACL tears. I think everyone's familiar with this, but just to kind of recap, we know that ACL tears are 4 to 8 times more common in women, or that a female athlete is more likely to sustain an ACL tear than a male athlete. Over 200,000 of these occur each year. We know that 1 in 100 girls will sustain a serious knee injury, and that this is most common between the ages of 15 to 19 in sports such as basketball, gymnastics, lacrosse, and soccer. The cost of an ACL tear is not just about the surgery, the imaging, and the rehab. It's also about the time off from work or from school, the loss of a scholarship or recruiting opportunity, the taking time off to go to physical therapy for many months afterwards. And it's been estimated that the aggregate healthcare cost related to ACL injuries is over $7 billion per year. And like I said, even though it's also about scholarship and recruiting opportunities lost, it can also be career ending because there's fewer opportunities for women to play professionally. And so the end of the season at an inopportune time can be, you know, the end of a career. When we look at the numbers in terms of ACL injuries, even though we're far enough out from Title IX now, we're still continuing to see the rates of injury climb. The numbers of ACL procedures that are being performed is still growing 3 times faster than that of males. And when we look at these ACL injuries, this is a comparison of, or this is looking at the mechanism of injury for female athletes and in ACL tears. And we can see that the majority of these are non-contact injuries. And when we think about non-contact injuries, this means, a player goes to pivot or cut or jump, the knee gives out, and then they have this injury. It's not always a collision, as we know. And when we look at these sports, comparing the same sports for males and females, we know that women are more likely to have non-contact ACL injuries, regardless of what sport that they're playing. So why is this? Well, a lot of discussion about hormones in the past. What we currently know is that sex hormones play a role in ligamentous laxity at the molecular level. So these older studies have looked at estrogen, relaxin. We know that this can decrease collagen synthesis. We know that this can decrease the tensile properties of the ACL. But these are really molecular studies. More recently, there's been a focus on the clinical relevance of these hormones and sex hormones. And Jason Dragoo's group, he used to be out of Stanford, looked specifically at relaxin, which is a hormone that's very similar to insulin and ILGF, which alters the property of cartilage and tendon by activating collagenase. Also has to do with bone remodeling. And basically, he looked at serum relaxin concentrations in Division I female athletes, and almost half of them had a detectable serum concentration level. Of these, 14 had an ACL injury, and the mean level for them was 12. Of those who didn't have an injury, the serum concentration was 5. And so they determined that if you had a level that was greater than 6, then you had a 71% sensitivity of predicting an ACL injury and a relative risk of 4. So this is an important thing where we're starting to really see this relationship between hormones and ACL injuries. However, when we look at this, it's not a clear relation, it's not a clear line and a clear causation. There have been studies that have looked at the relationship between the menstrual cycle and ACL injury. It's been reported overall, if you look at the meta-analysis, that the lowest risk might be in the luteal phase. Does this mean that women should only play soccer certain days out of the month? We're definitely not to that point. I think the difficulty here is understanding that the association between hormonal fluctuation and ACL injury is that the results are still mixed. What we do know is that there's increased laxity related to estradiol levels, but the clinical significance is unclear. A lot of these studies show that with this fluctuation, the difference in the laxity is less than 2 millimeters. So is this something that's really leading to injury? The next step with this is, or the next question becomes, well, is there a role of oral contraceptives in prevention? And really, while there are some studies that have suggested about a 20% reduction in the risk of injury, overall, if you take all of these studies together, the evidence is still low and the study design qualities are poor to fair. So this is not something that's currently the standard of care. One of the more recent studies that I'm most excited about is another follow-up study, again, out of Jason Dragoo's group at Stanford. And this was a rat study, but they looked at oral contraceptives and then they looked at the 5 different ratios, and then compared it to a control group. Because as you may know, oral contraceptives have different dosages and ratios of estrogen versus progesterone. And they treated 36 rats, female, of course, for 4 estrus cycles. And what they found was that those who were treated with this OCP formulary had significant increase in ACL strength. But what they also noticed was that it was in the order of highest to lowest progestin to estrogen ratios. So basically, the higher ratio formulations increased type 1 collagen expression. Although in this study, there was no change to structural load to failure when they were testing the ACLs, they did basically conclude that oral contraceptives with a greater progestin to estrogen ratio may have a protective effect. And I think that this is really one of the first studies to really get into the details of how we might be able to implement this in clinical use. But overall, I would say currently as it stands, as we know, as we understand the data, there's some limitations in clinical applicability, meaning that That was a rat study. I think there are dynamic shifts in hormonal levels, and so it's difficult to track. There are patient-specific sensitivities and patient-specific levels, so you might not be able to extrapolate based on one. There are interactions of hormones, and there's also, how hormones can influence not just the ligament itself, but maybe your movement patterns, maybe your risk-taking activities, and so we can't just make it a direct linear relationship, but certainly this is an important consideration. What we do know is that the most modifiable risk factor in ACL injuries for women is neuromuscular control. And when we talk about this, we all know that the risk factors are in the landing mechanics. So when somebody lands, that position of injury is what we call dynamic knee valgus. So you can see in this knee here, it's not actually a knock-kneed position, but it falls into that when somebody's landing from a jump or in some sort of deceleration motion. We know that with dynamic knee valgus, this is increasing your risk of ACL injury. And it's not just about what happens at the knee, but also related to hip adduction, which accentuates that valgus, landing in less knee flexion, having poor trunk control, because that can accentuate the dynamic valgus as well, greater motion in the coronal plane, and then quadriceps dominance, because as we know, the hamstrings are an ACL agonist. In women, we specifically know that without injury, if you take normal control populations comparing males and females, women naturally have a lower hamstring to quadriceps ratio. They have greater peak knee angles and greater dynamic valgus on tuck and drop vertical jump. So this is a natural thing that natural risk factor that they have. They also tend to have more lateral trunk lean and knee abduction moments, indicating they have less trunk stability. So these are all important components that are more common in women. And one of the biggest studies, not necessarily the first, but one of the most important studies in this space was by Bert Mandelbaum when he took over 1,000 players and enrolled about half of them into one side where they were doing some exercises during their warm-up for soccer with some preventative exercises to address some of these deficits that women tend to have. And then the other half did a regular warm-up. And what they reported was an 88% decrease in the rate of non-contact ACLs in the first year and a 72% decrease in the second year, which is pretty impressive. And even though there's been a lot of discussion about this over the past 20 years, what we know now is that these actually work. Kate Webster and Tim Hewitt recently did a meta-analysis of a meta-analysis. So they included 8 meta-analyses, each with up to 16 primary sources and up to 8 randomized controlled trials. And they concluded that, by synthesizing all of these studies together, there was a 50% reduction of all ACLs in all athletes and a 2/3 reduction for non-contact ACLs injuries in female athletes. So this is a pretty drastic difference. So which ones, who does this work in? Well, we know that the younger you are, the more likely you are to have benefit from these preventative training exercises. This meta-analysis looked and found that if you're between the ages of 14 to 18, your odds risk was down to about 1/3. Or less than that, about half in late teens. And then if you're over the age of 20, didn't really show a significant difference, at least in these studies. In terms of what components of the preventative training exercises work, we know that there's lots of different exercises that incorporate balance, plyometrics, strengthening, and proximal control. This study, again, by Hewitt and his group, found that there were fewer ACL injuries in the exercises that incorporated strengthening, proximal control exercises, so hip and core, and those that incorporated multiple exercise interventions. So these preventative training programs focus on improving neuromuscular control, and a lot of these studies have reported up to a 90% decrease in the incidence of ACL injuries, basically decreasing the rate of ACL injuries in females to that of males. So if you knew, or if everybody knew, that their daughters or their sisters or themselves were 4 to 8 times more likely to tear their ACL than male athletes, and that you could reduce that risk by 90%, you would think that everybody would be doing this. Every soccer club, every PE class, everyone would be doing it. But that's actually not the case. And this was our study from a few years ago, surveying 440 NCAA female athletes. And what we found through the survey was that almost 90% of these said that they would perform preventative training exercises if they knew that it could prevent injury. But only a third had ever heard of this concept. And this was in, the survey was distributed in about 2017, so pretty recently. Only a third had heard of this concept, and only 15% had ever undergone any sort of preventative training. We know that the number needed to treat is about 89. So for every 89 athletes that do the preventative training, we can maybe prevent one ACL. And a decision analysis model has shown that if we were to implement this universally, we could reduce the incidence by a couple percent, which would be a big deal. So this is where the community outreach aspect of this program comes into play. I think it's really important, not just to write about this in the books and in the journals, but really make sure that our athletes and our coaches understand what this is about. And so this is where we've put some effort into getting funding and to work, I think, next steps in terms of standardizing this teaching and quantifying these risk factors for injury and making sure that we have better tools to screen. Moving on to sex-specific outcomes, not a lot of data comparing males and females, although we are starting to see a little bit more over the past couple years. One of the biggest studies that I know of looking at 20-year outcomes after ACL surgeries show that women tend to have lower functional scores, more activity-related pain, and they're less likely to participate in strenuous activities after an ACL surgery, although they are less likely to have a re-injury of their graft. But this raises the question of whether we should be thinking about sex-specific treatments. So I'd like to raise, one example and one typical scenario. So the femur on your left is a male femur. The one on your right, we can call a female femur because it's smaller. When we do an ACL reconstruction, we try to place the ACL tunnel right in the center. That's anatomic, and leave about a 1 to 2 millimeter back wall here. And when we do it, so say this is a 10 millimeter tunnel. Well, if we do the same thing with the same size tunnel in a female, then looks like we've blown out the back wall. We no longer have that 1 to 2 millimeter rim, which is so critical at the time of the surgery. So what do? We move this forward so that it fits. And now the center of that tunnel is in a little bit of a different place. Well, does that matter? I don't know, but I think we should know, and I think these are the things that we should start to think about as we get further in this area. What we know currently is that female athletes, or any females, in general have an ACL volume that's about 70% the size of males. But if you equalize this for body height differences, then there was no difference. So basically, this study showed that the smaller the patient, the smaller the ACL. And even though there's a lot of data showing that the smaller your graft is, the more likely you are to have a re-injury, a lot of these studies haven't actually incorporated gender or height and weight. And I think that's important. Again, smaller graft, this is another study showing that the smaller your graft is, the more load it can handle. But how much load do we actually need in a small patient? Can a smaller, would I, for example, need the same size ACL graft that an NFL linebacker would? And would I be able to put that same amount of stress through my knee? Probably not. This is one study that kind of points to that, comparing males and females with ACL injuries based on MRI, and males were more likely to have a deeper femoral notch sign. So this means, a greater sort of forceful subluxation, more medial meniscal injuries, more concurrent LCL and PCL injuries. So this means, suggests that these secondary signs and associated injuries suggest that males might be able to put more force through their knee at the time of their ACL injury. So these are the considerations that I think are important, and it's not just in sports. We've seen this in arthroplasty. Zimmer has their female knee, and I think a lot of this has to do with implant size and also the forces and the loads to failure, like I just talked about. And I think that we're all moving in the direction of performing individualized surgery, and I think this concept is relevant to all subspecialties, and I think that this is an area that's going to continue to grow going forward. Sports expertise. So I think that everyone on this webinar probably has seen this picture before. This is showing all of the phases of the overhead throwing or the overhead pitching phases. This is something that we had to learn for our orthopedic boards as well as our sports medicine boards. It's in the chapter. We've all memorized this. We know it. It's a common part of our standard education. But how much do we actually know about things like fast pitch softball and windmill pitching, which is, a female sport, about the injuries that we see in gymnastics, or all of the positions in ballet and dance injuries, or what happens during equestrian, also primarily female injuries. This is one of my friends, Lou Schoen, who's a foot and ankle surgeon, demonstrating his turnout, because I think that for all of us who take care of athletes, being able to understand the sport, understand the mechanism of injury and the risks that an athlete is facing is part of being able to give excellent care. And the more we understand about female specific sports, the better care we're going to be able to provide. General considerations: in general, women are about 3 to 4 inches shorter, about 30 pounds lighter, 8 to 10% more body fat, and about 40 to 45 pounds less of fat-free weight. We have narrower shoulders, which means there's less muscle mass in the upper extremity. Women have shorter extremities. So if you think about physics and the moment arm and having shorter extremity, that's less force generated. So there are a lot of elements that are just biomechanical in nature. A wider pelvis can lead to a lower center of gravity. When we look specifically at the other side in terms of comfort level and what's different in our interactions, this study out of the athletic training literature rated the comfort level of male or female athletes with male or female athletic trainers through these hypothetical scenarios. And basically what they showed was that males didn't really have a significant preference between male or female clinicians, except when it came to like gender specific type conditions. But females did, even if it was an upper or a lower or mid-body injury and not just something that was, considered female specific. And so this doesn't mean that men can only treat men and women can only treat women. That's definitely not the case. But I think that these considerations are also important to understand why and where an athlete's coming from in order to be able to provide for them. Overall, we know that female athletes tend to have specific needs for multidisciplinary care, and it's essential to be able to incorporate this knowledge into orthopedic care to really provide what I think is a patient-centric model of care, especially for the female athlete. So we'll spend the second half of this talk kind of talking about these different disciplines that intersect with sports medicine and orthopedics. So eating disorders, I'm sure many of you are familiar with this concept. What we know from some of the older studies is that over a third of Division I female athletes have been shown to have some sort of symptoms or attitudes placing them at risk for anorexia. This is most common in athletes playing aesthetic sports, so things like gymnastics, bodybuilding, or diving, or endurance sports such as track and field or swimming. And when we look specifically in those groups, in the aesthetic or weight class sports, 2/3 of these women have been shown to be affected by an eating disorder. So this is a big number. Historically, we used to talk about the female athlete triad, where some sort of anorexia leads to malnutrition. Then this can offset the hormonal axis and lead to amenorrhea, which can then disrupt bone metabolism and lead to calcium and bone loss, and then that can lead to stress fracture or osteopenia. More recently, over the past 10 years or so, the criteria have changed a little bit. They're not so strict, and now this incorporates low energy availability with or without disordered eating, because a lot of athletes just don't even know that they don't have enough nutritional intake. Any sort of menstrual dysfunction, so not complete amenorrhea, and then a low bone mineral density. And with each of these factors, your risk for stress fracture increases. So we decided to look at this in our sports medicine clinic to really understand how many of our patients are affected by abnormal eating patterns. And what we found in our clinic was that 8.5% of our male patients and 24% of our female patients were considered to be at risk based on the EDEQ survey, which is a validated survey looking at eating disorders. So women were 3 times more likely to be at risk. I would also point out that 1/3 were reporting subjective or objective binge eating, purging compulsive exercises in the prior 28 days before their orthopedic visit. This was common in both women and men. And so I think, you know, as orthopedic surgeons and athletic trainers, physical therapists, even though we're treating the musculoskeletal aspect of these injuries, I think understanding this relationship between nutrition and injury and healing is going to continue to be important as we go forward. Concussions, hot topic. There's a lot of information about this currently. Some information starting to come out about the differences between women and men. What we currently know is that female athletes are at increased risk for cognitive impairment after a concussion. So if you take a male and a female athlete 7 days after the concussion, the female athlete is more likely to have an impaired reaction time and memory and increased symptoms even with the same injury. Why is this? Well, some of the factors that have been described: one, women have reduced neck size and strength, so this could lead to greater head displacement at the time of the injury. This has been shown in female rugby players that there may be some different mechanisms involved as well. Some hypotheses also include a smaller head to ball ratio for women who play soccer, but overall these studies are limited due to the different sports that males and females play, or if they do play the same sports, different rules, different field sizes, different equipment. But I think this is also, again, important to consider because we now know that after a concussion, your risk of having an orthopedic injury is over threefold higher. So looking at this data from the NCAA, this looked at 90 concussions in 73 athletes, and after they returned to play, they were followed for 90 days. And those who had recovered from a concussion were 3 times more likely to have an injury. We also know that athletes who have had prior concussion had also increased knee abduction moments. So going back to that whole ACL discussion, so your lower your impact score is for concussion, the more likely you were to have these sorts of biomechanical changes that put you at risk for an ACL. And then this more recent study showed that the time since the concussion influences your drop landing biomechanics. So all of these things, I think, still tie in to the commonality of the female patient. And is there a communication gap? So this is actually out of the arthroplasty literature, so it's not a sports medicine paper, but I just think this was so interesting. So this was a study out of Canada and a series of studies. And basically what they did was they had some actor patients who are male and female, same x-rays, same history, same physical examination. I don't know how they got this through their IRB. It would be impossible to do now. But then they underwent blinded assessments with 71 physicians. And then they brought in mock family members who then came in and recorded the elements of the conversation, informed decision-making, and rated the interpersonal skills of the physician. And what the study found was that male patients were more likely to receive a discussion of the nature of the decision and their preference for having a knee replacement. Physicians were including fewer elements of informed decision-making for females. They were rated as having poorer interpersonal skills with female patients, such as being less likely to show interest in you as a person, or talking down or not talking down to you. So these are the kinds of things that were different. And then the most striking thing, though, is not the interaction, but the fact that male patients were recommended for total knee arthroplasty 22 times more often by orthopedic surgeons than female patients were. This is with the same same history, same x-rays, and same physical examination. And when they did the same study when there wasn't these model actor interactions and the scenarios were on paper, the patient gender actually did not influence that recommendation. So there's clearly something. It's not bias. It is just a difference in the way the communications are interpreted. And I think that this also is an important area to focus on going forward. The last part of my talk is going to be a little bit about pregnancy. Obviously, this has come to light a little bit more as we've seen more and more female athletes who have competed or come back from pregnancy. Carrie Walsh was one of my classmates at Stanford, and of course, she announced after she won the gold medal that she had been pregnant during the Olympics. And we know a lot of these stories. And I think, you know, we haven't historically studied musculoskeletal disease during pregnancy, but as we start to see more and more women remain active during that time, I think we do need to know more about it. In our study, just surveying pregnant women, we found that a quarter of them had severe knee dysfunction, and that this was more common if you had higher activity levels, were younger, and had a greater BMI, or had a history of prior knee problems. When we see these patients in our clinic, it can be very confusing because in an orthopedic training program, we don't actually learn a lot about how to manage pregnancy. And so we develop these guidelines during a close collaborations and meetings between us and primary care and our obstetrics teams. And basically what we know is that, you can have a knee x-ray or a shoulder x-ray and there's not going to be any increase in fetal anomalies or loss. It's considered safe. You can do things to make it even safer. You can collimate the beam, you can position and shield to avoid irradiation of the pelvis. But generally, if a patient comes into my office with a knee injury or a shoulder injury and they're pregnant, they're still going to get x-rays if it's important for their care. You can also consider alternative imaging. So MRI has generally been shown to be safe in all trimesters. Gadolinium, which is contrast, is a teratogen and should not be used. Ultrasound, of course, generally considered safe as well. Patient in the office. Well, what can we offer as treatments? Well, NSAIDs are actually contraindicated, especially to affecting implantation and causing premature closure of ductus arteriosus. And there's other risks to the fetus that have been described as well. So generally we stay away from things until after labor. Cortisone and prednisone, however, are generally considered safe. There are some theoretical risks of cleft palate in the first trimester with very, very high doses, systemic doses. But typically we're talking about an injection. It's localized in the joint. And this is something that I've gotten the blessing of the obstetricians for, and has been a nice option for the patients who aren't able to take anti-inflammatories. If they are going to have surgery, again, this is pretty uncommon. If it's elective, they should delay until after the surgery. But if someone does need to have surgery during pregnancy, the second trimester is safest. And this is because there's the lowest term of preterm contractions on spontaneous abortion during this trimester. But there are considerations such as positioning. You need special type of anesthesia, obstetric anesthesia, because pregnant women have increased oxygen consumption and decreased pulmonary function. You need to have perioperative monitoring by obstetrics. So there's a lot that goes into this process. Also very important to remember that pregnancy is a hypercoagulable state. So early mobilization is important. Heparin is actually okay, but warfarin, Coumadin is not. So again, things to consider. And lastly, this case report that we published, I guess 5 years ago now, really kind of captures all of what we're trying to do here. So this was a 29-year-old female who was 6 weeks postpartum and was holding her infant, and then had this kind of subluxation of her wrist of the scapholunate joint. She was symptomatic and she had bracing, she had OT, and she continued to be symptomatic and had subluxations of her wrist. Turns out she was a surgeon. It wasn't me. Turns out it was a surgeon, and couldn't, had difficulty doing her job, and so was considering having operative intervention. And, I think that would be anytime you go through conservative management, you're still symptomatic. I mean, I think everybody would have agreed that operative intervention at that point was not unreasonable. And she had mentioned it to her obstetrician, who basically said, "Are you crazy? Just stop breastfeeding and it's going to go away." And so she did, and it did. And it never came back. And I think that was really an eye-opening moment for our department and for all of us, because something that was such a no-brainer decision for an obstetrician, was something that it has never crossed our minds in terms of our indications for surgery. And so this is why we need a women's sports medicine program, this ability to provide comprehensive care for the female athlete and promote awareness about the issues that affect female athletes, but also to advance the knowledge regarding the diagnosis, treatment, and outcomes in both current and future female athletes. And this happens through collaborations both within and outside the department. like I talked about, it's a lot of disciplines, and this multidisciplinary approach allows us to think outside the box and challenge the existing models of gender in sports medicine. Our experience has grown from pregnancy. We are building a female athlete HIP program. We are building women's sports-specific protocols and looking into sex differences and outcomes. We have educational programs, and we have a new women's sports injury and performance clinic, which has been a great way to provide, again, a physical multidisciplinary clinic for our female patients. So the reason why I care is not just because I was a female athlete or that I think that women should take care of women. It's because I believe in our ability to change the field that we work in. And I see women's sports changing the same way that I see the field of orthopedic surgery changing. Even for myself, 20 plus years ago, when I was a medical student, my own advisor told me that I couldn't become an orthopedic surgeon because I was a woman. And luckily, I was able to train at a great program where I had a lot of female mentors in my orthopedic surgery program. But then when I applied for sports medicine, I was told repeatedly that they couldn't have women in the locker rooms and that they weren't sure about having a female fellow. And again, I was lucky enough to train at HSS, but then when I applied to my first job, it was the same issue of, well, we don't want, the trainers won't work with women and we think this is a barrier. And luckily a man named George Paletta vouched for me, and that's how I ended up being as a team physician for the St. Louis Cardinals and being the first woman to hold that role. And now, because of that, I get to mentor young women all the time who email me and say that it's their dream to become a team physician for the NFL or for the NBA because they've never been told that it's not possible. And that's how change happens. And so I think it's our responsibility to push for this change for our athletes by knowing the anatomy, the outcomes, and the context of sport for female athletes. The opportunities for female athletes are continuing to grow, and I believe that our daughters and granddaughters are going to have opportunities to play sports that women of our generation never even dreamed of. And with this, there's a need for more sophisticated knowledge of the treatment and outcomes in women to allow them to stay healthy and continue on to the next step. So where will you be when the first woman pitches in the majors? Well, I certainly hope this happens at Fenway so that I can see it for myself. I definitely believe this is a possibility within my lifetime, and I hope you'll all join me in supporting these women to get to the next step. Thanks very much for your attention. Just a little plug for the new Journal of Women's Sports Medicine. You can follow us on Twitter and catch our publications online. Thank you.
All right, wonderful. Well, I am going to wait for some of these questions to start popping up. I will say, just as an FYI, we had about 115 people, it looks like, attend, and certainly a variety, quite a few predominantly athletic trainers, lots of returners. Erica says, great presentation, no questions. We had a mix of males and females. Okay, Michelle has a question here, and she asks, how do you address the misconception concerning female athletes missing periods being normal and not an energy imbalance, especially in those who may also be trying to lose weight?
Yeah, I think, that is a combination of education on the individual level, but I think that a lot of this has to do with changing the culture, right? And so it's not just having that conversation, but making sure that we raise awareness about these these issues, and how dangerous this problem can be. And I think that that's really the crux of what we're trying to do through these women's sports medicine programs, is not just the one patient at a time, but really changing the overall understanding, the common sort of conceptions or misconceptions, from really trying to change how the athletes and coaches think. So I think the more that we can collaborate together and have outreach programs and kind of educate people about their issues and injuries, the more likely we are to be able to kind of capture more a broader audience.
Danielle says, good job, Dr. Tanaka. We miss you at Hopkins. Maybe?
Hi, Danielle. Thank you.
Okay. And Dylan asks, how would you deal with issues with female athletes who have to cut or lose weight for sports such as wrestling, mixed martial arts, boxing?
Yeah, so I usually have, I mean, obviously I don't really do the nutrition counseling, but I think that having a nutritionist who can really balance out all aspects of that weight loss, not just from a caloric standpoint, but considering the training demands, and also understanding the flip side of what happens if you go too far with that, and being able to educate the female athlete about what to watch out for, and how to know that this isn't, when it's become unhealthy. So kind of putting those guardrails in place. So I guess I would say finding a nutritionist who is comfortable kind of talking about these issues and educating women specifically about them.
He said, thanks. All right, very good. Well, then I would think that's a great time to wrap it up. And I do appreciate, Dr. Tanaka, your time tonight. Thank you so much for joining us, and thank you for sharing your expertise with so many people. I know that it's really going to impact patient care here. And if there are any other questions, we will forward them as emails to you.
Sounds great. Thanks so much for having me.
Absolutely.